Great, thank you. Hi, everyone. Thanks so much for joining us today. My name is Lauren Pongin, and I'm the National Director of the Diverse Elders Coalition. I use she and her pronouns. The Diverse Elders Coalition, or the DEC, was founded in 2010, and together the coalition advocates for policies and programs that improve aging in our communities, which are racially and ethnically diverse older adults, American Indians and Alaska Natives, and lesbian, gay, bisexual, and/or transgender people. Our coalition is made up of 6 different organizations that represent those constituents, including the National Asian Pacific Center on Aging, the National Caucus and Center on Black Aging, National Indian Council on Aging, SAGE Advocacy and Services for LGBT Elders, and Southeast Asia Resource Action Center, CRAC. Finally, our 6th member is today's co-host, the National Hispanic Council on Aging, or NHCOA. For 51 years, NHCOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. So I'd like to thank you again for joining us today for this webinar, Lessons from the Field, Conducting Health Research with Hard-to-Reach Populations. We have an incredible panel of researchers today who will shed light on best practices, lessons learned, and tailored strategies for reaching diverse populations. Diversity and inclusion have been at the forefront of national conversations, from sports to legislation to boardrooms and to the census. It's extremely timely to understand ways to meaningfully and respectfully engage the hardest to reach populations for inclusion in health research, including the All of Us Research Initiative. To get us started and to kick off our panel, I'll briefly introduce our panelists. So today we'll be hearing from Florencia Gonzalez, who will cover conducting health research in the Hispanic community, Lynn Chong, who will talk about research in diverse Asian American, Native Hawaiian, and Pacific Islander communities, Dr. Ann Simpson, who will share her expertise around health research in the Black and African American community, Dr. Turner Goins, who will speak on research in American Indian and Alaska Native communities, and last but not least, Dr. Maria Patani will share her learnings from the largest, most comprehensive study of the Latino population in U.S. history. After each of these researchers has presented, we'll have an opportunity for Q&A, so please feel free as questions come up to put them in the chat box. We'll save them for the end and after each presenter has gone. So today I'd like to start by introducing Florencia Gonzalez, MPH. She's the co-director of the Inclusion of Diverse Populations Core under the Georgetown Howard University's Center for Clinical and Translational Sciences. She also serves as community liaison for the center's Community Engagement Core. She specializes on leading efforts to establish community academic partnerships for inclusion of underrepresented groups in health research. She also supports investigators in the implementation of community and patient-engaged best practices. She has prior experience managing clinical trials and overseeing disparity health research within community settings. Additionally, she has a history of grassroots field experience conducting case management with immigrant populations and managing public health projects in cross-cultural settings, such as Sub-Saharan Africa and Honduras. While Hispanics make up 17% of the US population, they only comprise 1% of clinical trial participants nationwide. Let's hear more from Florencia about her work at Georgetown Howard University's Center for Clinical and Translational Science. Welcome, Florencia.
Thank you. Happy to be here. So I'll start off by telling you a little bit more about my center, where I work. We are a multi-institutional consortium founded out of a need identified by NIH's NCATS for enhancing clinical research infrastructure and helping address barriers researchers often face when conducting research. And our consortium includes 5 institutions. It includes Georgetown University, Howard University, MedStar Health Research Institute, the Washington, D.C. VA Medical Center, and Oak Ridge National Laboratories. Next slide. Our aim is to foster multidisciplinary collaborations. We have a strong focus on health research among underserved populations, including older adults, people with disabilities, people from diverse racial, ethnic, and cultural backgrounds, racially and ethnic diverse people residing in urban settings, and veterans. We provide an array of support services for investigators at our institutions, including consultations on best practices for building community academic partnerships, community engaged research, patient engaged research. We also provide expertise and resources on the integration of culturally and linguistically competent approaches for integration of diverse populations in research. These consultation services are also extended to our community partners. So my focus of this presentation will be tailored towards investigators. As I understood, that would be the majority of the audience. If there are audience members that are part of the community, we also provide resources and support to community partners within the DC metropolitan area. We also provide opportunities to connect with our community advisory board and our patient advisory board for input on improving the recruitment approaches towards research and the implementation of research. And we attend community events to raise awareness of clinical research participation and gut studies. Next slide, please. So as we all know, the disparity between the policy of inclusion and the actual practice of inclusion among research institutions nationally continues to be disproportionately affected. It continues to disproportionately affect racial and ethnic groups across the lifespan, including members of the African American community, Latino X, American Indian, Pacific Islanders, Alaskan Natives, and Asian American communities, as some of my colleagues will go into more in depth today. I won't go into the statistics of the Hispanic population as it was already presented. However, I do want to point out that there was a study. If you can go back one slide, please. There was a study that I was looking at recently, published in 2019 in JAMA Oncology, and it looked at 230 cancer clinical trials. And of those clinical trials, whites represented 76% of the study participants, Asians 18%, Blacks only represented 3%, and Hispanics 6%. What was really interesting is that not all the studies reported, of the 230 studies that were looked at, only 2/3 of those studies reported on race and ethnicity. And only 18 clinical trials split the data into 4 major racial groups: white, Asian, Black, and Hispanic. So this just goes to show you that looking at race and ethnicity and the diversity of race and ethnicity in research is still not a priority for all researchers, and we have a long way to go. Next slide, please. And another group that I think is really important that we think about in terms of strategies in addressing barriers to inclusion are individuals with limited English proficiency. The disparity between policy and practice of including individuals with limited English proficiency is even greater. There are many barriers that we have encountered in our experience with investigators not including people with limited English proficiency into health research. If you can go into the next slide, please. So in looking at these barriers, we noted in our experience that many times items are just not, or needed resources are not budgeted, such as transportation, childcare, meals. There's lack of flexibility among research team members and investigators where individuals who could potentially participate are not able to do so within working hours. And so flexibility is really needed where study-related activities could take place in evenings and weekends. There's lack of quality language access, no bilingual staff members or certified interpreters. Family members and friends are not adequate for interpreting during medical appointments and also research-related appointments. Documents are not translated in the participant's language of origin. Low health literacy, oftentimes, especially in the Latino population, we have found that there's a proportion of our population with low health literacy, and this needs to be considered in how the consent forms and the surveys are written so that they are clearly understood and a well-informed consent process takes place. And bottom line, many times individuals who do not speak English are just not being invited. Next, please. So what I'd really like to do here is I'd like to share some of the resources that we have developed through our GHUCCTS enterprise, and tools that we use during our consultation services and in presentations and training sessions for our investigators. And we also use some of these tools in partnership with our community partners in research. So first, I'd like to share, how many more minutes do I have, please? First, I'd like to share information about our demographic form. And this form was developed to share with our institution investigators to ensure clinical research participant samples are adequately represented in research. So we want to promote this tool with our investigators, as not all investigators are capturing diversity data. We are going to pilot this survey to evaluate comfort level of questions among participants, because some of these questions are quite sensitive. Next, please. So I cannot show you the full survey, as it is a couple pages long, but what I do want to point out is that these are the variables or the fields that we are collecting and what we consider to represent diversity. Diversity for us is not only racial and ethnic diversity, but also nationality, tribal affiliation, sexual orientation, gender identity, socioeconomic status, religion, and so on. And so the point here is that the identity and diversity is multifaceted, and we are a very complex being, and many times there is an intersectionality of these fields or these forms of self-identification. And that is really important to keep in mind also when conducting research. Next, please. So here is a example, and I'm not sure if you can see the questions, but these are some of the questions that we do encourage investigators to ask in their studies as part of what we consider diversity, and to learn about whether the patient speaks English or doesn't speak English, and that way being able to adapt to the needs of that person. And the degree of how well they speak English, gender identity, sexual orientation. Now, I will say that this survey is not perfect. It took us a long time to develop. It was inspired by our community advisory board, and you know, it's still in the works, but at least it's a start. Next, please. With the race and ethnicity question, I don't know if you can zoom this out. With the race and ethnicity question, we took the model of the 2020 census, though we kept in the various categories that some of the categories were deleted from the census, such as the category Middle Eastern and North African. Again, it's not it was challenging to find the best way to capture ethnicity, race, and ethnic identity, or national identity, but we felt that this was the most comprehensive way to do it. Next, please. So this is our language access guide. We developed this guide in particular to support investigators in the inclusion of people with limited English proficiency into research. It is quite a comprehensive document. We put a lot of time and effort into it, and we do share this within our consultation services with our investigators to promote the importance of following best practices around inclusion of people with limited English proficiency in research. And all of these resources that I'm sharing today, I will be more than happy to discuss further in detail. Feel free to reach out to me, and I will put my email address at the end so that you can reach out to me. Next. I'm not sure if that's 2 minutes or 1 minute, but I will go quickly. So it's really important to consider the budget. If you don't have the budget to include people of diverse backgrounds, and in particular people of limited English proficiency, then it's going to be very difficult for you to include a diverse population in your research. And it's important to keep these in mind, whether it's a sponsored trial where you want to negotiate with your sponsor about the items that you need, or the budget items you need, or whether it's an investigator-initiated trial where you budget it in from the very beginning. So, again, this is something that we could talk more in depth if you would like to reach out to me in learning more about our approaches to how we address our budgets for inclusion of diverse populations, in particular people with limited English proficiency. Next, please. And lastly, what I'd like to share is that institutions have a lot of opportunity, have great opportunity to train investigators and to train staff on best practices around inclusion. And recently we conducted a training with our Howard University Hospital interpreters on the basics of clinical trials and the role of interpreters during a clinical trial and the difference between that and interpreting for a standard clinical visit. We also discussed specific study that they were going to be interpreting for and share the consent form, went through with it, defined some of the common terms used in that study, and of course, we're there to answer questions. Next, please. Though brief and quick, I hope this gives you at least a snapshot of the possibilities institutions can take to include people of diverse backgrounds, including those with limited English proficiency, that there are ample opportunities to do so. It's a matter of being creative and leveraging these services that you have in place. And if you have any questions, here's my email address, and that can be put in the chat. If that'll be easier to copy and paste, that would be great. Christine, if you wouldn't mind doing that. Thank you so much, and I apologize this was so quick.
Thank you so much, Florencia. That was really helpful, and I always love seeing and knowing that tools exist for inclusiveness, and sometimes it can feel like a lot to take on, but knowing that there is an entire repository of tools and a model for engagement, I think it's really helpful for everyone listening. So thank you for your presentation.
Thank you.
I wanted to remind all of our attendees that if you have questions, please feel free to type them in the chat box for the end, but we'll move on to our next panelist. So recognizing that data is a civil rights issue, Lynn, our next panelist, uses research to connect the dots between policy, practice, and people. In particular, she works to better illuminate Asian American, Native Hawaiian, and Pacific Islander, or AA/NHPI, communities' struggles and solutions. Most recently, she supported a social needs screening tool and intervention protocol pilot at a safety net clinic serving largely low-income and monolingual AA/NHPI patients. She has diversified the review of evidence and emerging practices for a statewide, city-level policy initiative on children's positive mental health, and she's co-creating an ethnic studies resource hub with 9th through 12th grade expert teachers. Lynn is pursuing her doctorate in health policy and management at UCLA Fielding School of Public Health. So we know that, sorry, are you ready to go, Lynn?
Yes, I'm so sorry about that.
okay.
Thanks to everyone who's on today. I really appreciate your commitment to ethical and responsible engagement with diverse populations. And as you may already know, many of the ethnic communities swallowed under the Asian American, Native Hawaiian, Pacific Islander umbrella have been fighting for decades to be seen and heard, and for their struggles, strengths, and solutions to be legitimized and validated by data. So I'm very glad to be here to share and support our community's inclusion and visibility. Next slide, please. I chose a photo of a data disaggregation rally just because I think what Florencia had mentioned around having detailed race and ethnicity data is really, really relevant for our communities. So as researchers, if we can close out more, allowing folks to self-identify if they don't see their community represented, and to make sure to report that out somewhere. So if, for example, you're publishing a paper and you have to collapse that information, making it a practice to include in supplemental material or available if asked by community members. Also making sure that for our mixed race and mixed ethnicity folks, giving them their opportunity to report out all their identities. These are really, really important for some of our populations that tend to have higher rates of intermarriage, and allowing them to still be able to be seen and heard in data. Next slide. Thank you. So while I recognize that research should always aim to be rigorous, objective, and rational, for it to be responsible to communities, it also has to be a lot more than that. And so for Asian Americans, Native Hawaiians, and Pacific Islanders, the fight for data disaggregation has been pretty central to our fight in civil rights as well. And research, community-grounded research, really is about allowing communities to determine for themselves who they are and what their solutions are as well. So I'll be speaking mostly as someone who spent a long time doing community work before she realized that the best way to support my community was through research. And I recognize that my opinions are mine and don't represent everyone else's opinion, and may not translate 100% to your work, but whatever insight I can give you, I hope that it is helpful. Next slide, please. I know that this is only 10 minutes that we have together, so I highly recommend you pick up Decolonizing Methodologies by Linda Tahiwai Smith. It's a lot of the ideas that I draw on in this presentation are also taken from this book. And it's also the starting point for EPIC, which is the Empowering Pacific Islander Communities nonprofit research agenda. I want you to note that there's a difference between a traditional research agenda and the research agenda that Dr. Tahiwai Smith lays out. And I want you to note that the heart of this is around the concept of self-determination, but that there are other concepts that are really important, including concepts of healing and transformation, mobilization and decolonization. And we don't traditionally think of these things as part of a research agenda, but if we're working with community members that have dealt with a long history of being oppressed or disenfranchised, in part by the research that we produce, these are considerations that we have to have in order to be ethical and responsible to the communities we serve. Next slide, please. And I originally meant for this to be engaged and for you all to be able to participate, but I realize now that you can't talk to us. So I'll go through this relatively quickly. I just wanted to give you scenarios of that I've had with government entities and also with some academic researchers trying to figure out where they could have improved in their outreach to Southeast Asian American populations, which is the population I worked with most closely recently. So for example, there were some folks who were trying to outreach to the Hmong community, which is a ethnic minority group that is in Southeast Asia, at a local festival, but they were having difficulties having people work with them. We also had an example where folks were hosting listening sessions across the state, but they weren't able to get the turnout that they were hoping for to get that community input. There's also situations in which you may be translating the documents, but people may not use them, or they may not still want to participate in your study. Or perhaps you've already partnered with a community partner and you're trying to get them that credit, for example, co-authorship, but they're not engaging somehow. So you're trying to figure out, what am I doing wrong? Next slide. Can we skip the slide too? Thank you. So for me, the first example around engaging community members at a fair or at a community event is that sometimes people want to find ways to do more niche marketing to community members. And I think that that's great, but I think that the overall way that we engage community members has to also shift. So doing culturally competent outreach, but also figuring out, how do we shift power when we do research with communities? How do we allow them to determine what the research agenda is? And not just say, how can I find you so that you can be in my study? And another book recommendation, if you want one, is Ruha Benjamin's Race After Technology, which is particularly relevant in the context of precision medicine and statistical learning, because she has a focus on discussing how algorithms can still be racist. Next slide. And so the next set of scenarios were around how do you engage folks that you've already partnered with, or how do you get folks to give you input when you've already invested the financial resources to engage them. Next slide. For this, I think this happens a lot. Sometimes when we want to engage folks, we don't know how much to include them in the conversation and how much is actually a huge drain on their bandwidth. Sometimes when you're working with community partners, they can be nonprofits that have really limited budgets and staff. They might be individuals that are not familiar with doing traditional research, and so they might not feel comfortable or confident in doing this work. And I think it's about figuring out on the front end what their values are and what their priorities are and how you can help them accomplish that, and then taking on the responsibility of the other components of the research project. Or it might just be that you may not have the relationship yet with some of these community members, and that has to be developed before folks are ready and willing to do that research with you. Next slide. And so, as we've already highlighted, there's a lot of conflicts that can happen, and that there's not a natural synergy that happens all the time. But I think that something else I wanted to mention is that not everyone's role is to do direct community outreach. It might be to ensure that there's detailed racial and ethnic data in your surveys when you build survey instruments. It might be to mentor the next generation of community researchers, or it might be as a journal editor to make sure that some of the research that's done on ethnic minority groups shows up in some of the mainstream journals and not just disparity related journals. Next slide. So I think ultimately it's about how do we make sure research is serving folks, and how do we equalize the playing field for folks, rather than just something that we do to a population. And I wanted to highlight that there's a huge difference between saying you're doing research in the field and saying that you're doing research with and alongside people. And also, if possible, not to use the term hard to reach, just because a lot of our populations are seen as under this deficit framework, right? Like we are the problem, and research for so long has identified the other as the problem. And we're really trying to move towards a place where we can say there are structural and systemic issues that make it hard for us to reach these populations, but they are part of the solution as well, and not another issue for us to grapple with. Next slide. And finally, this is just a quick summary. I'm not going to go through it because I think I'm out of time. And I thank you all for letting me join you today.
Lynn, you have 1 or 2 minutes if you do want to go into that last slide.
I'm sorry, I thought that you guys didn't have time. So I summarized some of the thoughts. I think the only other thing that I haven't covered is some of the theory. So things like positionality and reflexivity are discussed in Linda Tuhiwai Smith's book, but there's also a ton of research that has been done by some of these communities that I hope people read. Sometimes when we want to engage folks in community research, we have a tendency to want to work with them directly, but they may be a little exhausted, and so it's good to just take some time to do the reading and to cite the scholars in the field before we put that burden on them. And what else? I think that's the main thing I had. Thank you so much. Oh, and then this is from Empowering Pacific Islander Communities. So this is their research policy and procedures document. I offered it as a concrete example for folks to see what community grounded research could look like. And EPIC is just an incredible organization to work with if you're interested in working with Pacific Islander communities. If you switch to the next slide, it's just a quick summary of some of the culturally specific differences that FOM, one of my colleagues that's an ethnologist, is doing with me and folks. And so she was generous enough to share some pretty personal anecdotes for folks. And I wanted to share something that was a little easier for folks to tack onto, because I don't want research to be something that people feel is distant from them or is only reserved for a specific cadre of people. And FOM is a fantastic example of someone who's very grounded in the community, but also doing research.
Thanks so much, Lynn. As someone who's been in the Asian American, Native Hawaiian, and Pacific Islander space for a long time, I really appreciated your presentation and how you connected the dots between data as a civil right and the role of research and representation, while also providing a framework for how to do that meaningfully and over a long period of time, centering trust. So thank you so much for everything that you shared. And I think that will mold nicely to our next presenter, who is Dr. Ann Simpson. So Dr. Simpson is a University of New Mexico Health Sciences Center Emeritus faculty. She holds the following emeritus titles: Associate Vice Chancellor for African American Health and Executive Director of the Black Health Resource Center, Professor of Internal Medicine and Geriatrics, Russ Professor of Ethics, and Director of the Institute for Ethics. Dr. Simpson served as a clinician, educator, and ethics consultant for both research and clinical issues. She was the recipient of a 3-year NIH AHRQ research grant to evaluate training and provide ethics consultations throughout the state of New Mexico via telehealth as a part of Project EHCO, probably pronounced ECHO. Additionally, Dr. Simpson is a member of the board of the National Caucus and Center on Black Aging, which is one of the founding members of the Diverse Elders Coalition. So I'm already a huge fan of NCBA's work, and it's really my pleasure to welcome Dr. Simpson.
Thank you. Good afternoon, everyone. And I am going to talk with you from the frame of a physician and ethicist, and also someone who spent many hard years on an institutional review board. So I'm looking at considerations for how to engage the African American Black community in terms of research. The first thing, the most important thing, is to educate and to consider truth-telling while you're educating people. African Americans often ask, why is the public health experiment in Tuskegee the only atrocity mentioned when there have been so many other medical and research exploitations of the Black African American community? To list a few, Columbia University in the 90s did studies on Black and Hispanic boys, really trying to stigmatize them as criminals. This is a prestigious institution. The investigator, the last time I checked, was still there. There are genetic studies on babies and others without their consent. There have been sterilizations of women of color. There have been studies on prisoners, majority of them Black. There is also, maybe we don't think about it, the ethically impossible study that was done in Guatemala, where they actually did give those women and men syphilis. Now, the general press may not always pick up on these studies, but the Black press will. There have been Black newspapers for at least 150 years, and some of them are still going, more than 100 years old. There's the Amsterdam News, the New Journal and Guide, there's the Chicago Defender. So people read these stories. Blacks know about these things. The Black community is aware, and more members of the Black community have passed high school formal education. So how do I engage and educate them to engage in research? And it's part of a process, but I use the same process that investigators should be using and the rest of us should be using, and that I also use when I am engaged in research. I actually introduce them to laws and policies, Nuremberg Code, the revised Belmont Report, and the Common Rule, Title 45 of the Code of Federal Regulations. And more importantly, I have them to think about why on earth would they want to do research. That's an important question. Why do you want to do it, and how would you participate in it? And so what do we have to do? Is we have to think about the whole process of informed decision making. And that is critical, because if you know how to play the game, then that gives you more control. So how do you inform yourself? And you have to ask questions. But in order to be informed, you must also have the cognitive capacity. You have to be able to think about it, to manipulate the information. But you are not cognitively informed if you don't receive the information. So you need to have the information if you're doing it for yourself, or if you are the surrogate for someone else. So the information is important. Ask the questions. Ask questions about risk benefit. That is the anticipated benefit and the potential risk. So those things are important. You have to understand undue influence and coercion. These are things that are important for individuals as they go forward to participate in research, because there are people who want to participate in research. It's not that they don't. It's just about how they are engaged. And you have to think about self-determination, your autonomy, your right to say yes or no, your right to step away from the project if it's no longer appropriate for you. And you have to think about accountability, holding the investigators accountable as well as holding yourself accountable. It should be a partnership. What are the barriers for some investigations? Really, it tends to be investigators who do not want to participate at that level, who do not want the time to spend the time to do these things. My question is, as an ethicist, if you don't have the time to do that, do you really have time to do the research? So I want to also think about a success story. Maybe many of you know the Jackson Hart Study. It's a collaboration between two historically Black colleges and universities in Mississippi, Jackson State University and Tougaloo College. Their first participant in this 20-year study was September 26 in 2000. It is the largest single-site, community-based epidemiological investigation of environmental and genetic factors associated with cardiovascular disease among African Americans ever undertaken. And it now involves 5,300 men and women in the Jackson, Mississippi area. Their values, they value accountability, commitment, competency, collaboration, excellence, respect, teamwork, and trust. And they continue to maintain an engagement, their partnership, by continuing to disseminate summaries of study findings annually through newsletters to study participants at cohort and community events and by mail. And I was also asked the question, we were all asked, what to do if you're in a community, especially with COVID, and there is limited internet access. With limited internet access, I think I have 1 minute left. One, you have to consider the appropriateness of targeting a population without access. It's an ethical consideration. Would that be just? Would there be equity among those participants? And how would you be holding, who would you be holding accountable for being out in that community? Would it be yourself as an investigator, or would it be the participants? You have to circumvent web access, be creative, and also consider public media such as radio, television, and consider whether they are appropriate mechanisms. In addition, there are still newspapers, and some newspapers that target specific audiences. So really, the bottom line is be thoughtful, be inclusive, be considerate, and consider that the people you are dealing with are intelligent human beings. That's the end. Thank you.
Thank you so much. That was a really powerful presentation, and I loved how you provided some historical background and some larger context around outreach, specifically in the African American and Black community for research. So thank you so much for sharing all of that. Just another reminder, any questions as they come up, keep them going in the chat box for the end. And next, I will introduce Dr. Turner Goins to talk about health research with American Indian and Alaska Native communities. Turner received her MS and PhD in gerontology from the University of Massachusetts, Boston. She is the Ambassador Jeanette Hyde Distinguished Professor in the Department of Social Work, College of Health and Human Sciences. For the last 20 years, Dr. Goins' research has focused on American Indian and Alaska Native aging-related issues. She has had the pleasure of working with many tribal communities across the United States in the area of elder health along her longest collaborative relationship, which has been with the Eastern Band of Cherokee Indians. Turner's research adopts a community-based participatory research approach, wherein her research examines issues of local importance. She is a fellow in the Gerontological Society of America. Welcome, Turner.
Thank you. Good afternoon. I appreciate everybody here. Today I'm going to speak about my experiences in terms of engaging with tribal communities on gerontology related health issues. Next slide, please. And the first slide showed that I was at Western California University. I'm actually at Western Carolina University. Okay, next slide, please. So, who are American Indians and Alaska Natives? So it's generally understood that they're individuals that are enrolled or eligible to be enrolled in federally recognized tribal communities. Individuals or tribal entities determine for themselves. So each individual tribe determines for themselves membership eligibility. It's often with a minimum blood quantum or degree of ancestry to the tribe, but it does differ from tribe to tribe. There's not a single universally accepted definition of who's an American Indian or Alaska Native, as various cultural, social, political, and administrative definitions exist. So every year, the Federal Register publishes information from the Bureau of Indian Affairs of how many federally recognized tribal entities that there are. The most recent, there's 574 federally recognized tribal nations in the U.S. But not all American Indians and Alaska Natives are enrolled in a federally recognized tribes. Some persons belong to a state recognized tribe. I believe if not all state recognized tribes are east of the Mississippi. And others can self-identify as American Indian, Alaska Native, but not enrolled in a state or federally recognized tribe. Next slide, please. So there's about 2.7 million American Indians, Alaska Natives of any age. And the U.S. Census since 2000 has been identifying, it's all self-reported in terms of race and ethnicity. And you can identify a single race ethnicity or in combination. So when I say American Indian, Alaska Native alone, those report solely being American Indian, Alaska Native rather than in combination with another race or ethnic group. So when you look at the older adults, say 65 years and over, there's about 235,000 American Indian, Alaska Natives alone. And of these, less than half reside in rural areas. So there's a misunderstanding that American Indians and Alaska Natives are, just on tribal lands. In fact, I think about 60% of American Indian and Alaska Natives are in urban areas. However, when you look at older adults, which I do, as age increases, the proportion of American Indian and Alaska Natives in rural areas and or tribal lands increases. So appreciating and understanding the needs of older American Indians is only going to increase as the numbers of American Indians and Alaska Natives age 55 is going to increase. Next slide, please. So when you talk about research or engaging American Indians and Alaska Natives in communities, so my experience to date has only been with tribal communities. I haven't done any work in urban or areas in terms of recruitment and working with American Indians and Alaska Natives. So my experience has been solely working with tribal communities. And so it's important to understand for researchers that federally recognized tribes are sovereign nations. And so they have a nation within a nation status. So they have their own distinct government with executive, legislative, and judicial powers. And I think a lot of people don't understand that. And so what this translates into for many tribes is that they execute and they express their self-determination where tribes can establish their own institutional review boards. So I'm actually on a tribe's IRB, and so people, before they can do research on tribal lands with tribal members, they have to go through the tribal IRB. A lot of academicians don't understand or appreciate the needs of a tribe, the tribal community, history, or diversity. So my mantra is if you know one tribe, you know one tribe. And post-colonial relationships with state and federal governments can vary. So for one tribe, it may be a pretty good relationship and a historically good relationship, and other tribes it's not. And there's also different tribes have different array of social and health services, just like any community. Some communities have a lot of resources, some communities don't. And tribes, there's a lot of diversity across tribes in that respect as well. And there's also differences about beliefs around illness and rather than the biomedical assumptions that drive most of our health research. And so to address this barrier from the academic side is you've got to be prepared to do a lot of upfront work in terms of communicating and partnering and understanding and appreciating the community and what the community needs and wants at that time. It's you rarely have success approaching and pursuing a research project without prior communication and involvement with the tribe. Next slide. So from a tribe's perspective, there's a lot of horror stories, has already been referred to in prior presentations about researchers being insensitive and only coming into communities with a self-promoting attitude. That's quickly detected in tribal communities from my experience, and that's actually the expectation is as you approach a tribal community that you're coming from a very self-serving approach, and so you have a lot to prove with the tribal gatekeepers, if you will. There's a lot of skepticism and that the researcher is actually going to serve the tribe's needs. It's also important for you to realize that your research is not a priority of the tribe. It's your priority, but it's not the community's priority. It does help, however, if your project is designed to address tribal needs. So that helps elevate the value of the project to the community. And it's also important to be aware that your project can be an imposition on tribal leaders, tribal members, tribal employees. Next slide, please. So I echo Lynn's recommendation for decolonizing methodologies. I did spend 6 months in New Zealand, and I was able to take some great coursework on research methods, and there's a lot of great work and a lot of great thinkers in New Zealand around appropriate methodologies for Indigenous communities, and that's definitely a great book. So what's been around since '98 is the community-based participatory research tenets, and I'll move on, but I these are all very important tenets to guide your project. Next slide. There's been also what's been proposed is the tribal participatory research mechanisms. It was proposed about 20 years ago by Fisher and Ball, and it includes 4 mechanisms: tribal oversight of your project, culturally specific assessments, employing and training community members, and neutral facilitation of meetings between community members and research staff. And this was mostly, the 4th one was that a lot of their work was around substance abuse or misuse. And so when you're dealing with some highly sensitive topic areas, perhaps a neutral facilitation is necessary. I haven't found that necessary in my work. I also recommend that this tribal participatory research, these mechanisms include dissemination. Next slide, please. So some lessons learned. Acknowledge that your project can impose upon tribal leaders and members' times. Your timetable of when you need to get your project done may not and likely does not coincide with the timetable of people that you need to engage and buy into your project at the community level. Prepare for extensive upfront work, making friends, visiting the community, reconsider the prerogatives of academic freedom. So this comes to a shock for a lot of researchers, is that that the research collected, the tribe claims ownership of that data, and I don't think a lot of researchers are prepared for that. So it's a very different animal, and so that's something for you to consider, whether that's something that you can embrace or not, working with Indigenous communities. Also, it's important to instill project transparency. Also, this is an oversight for a lot of researchers, but budget accordingly. So if you have time demands on tribal leaders, tribal members, tribal employees, budget. Pick up part of their FTE if in fact they're allowed to do that. If you are imposing, if you need them to help you with the project, you've got to be flexible. And don't forget, your project is not their priority. It's your priority. So it's important to keep in mind. Next slide. Next slide, please. Oh, is that the last slide? Okay. And like I said, I serve on the tribal's IRB with a local federally recognized tribe. And, our guiding lens when we do look at protocols submitted by researchers is what's in it for the community, what's in it for the tribe. And so that's something for you to think about as you think about, a project idea that you're excited about and you want to pitch it to a tribal community, is what's in it for the community? Why should they participate? So thank you.
Thank you so much, Turner. I thought there was a lot of really great information in there, a lot of really pithy things that I think I'll take with me and remember. I really loved your mantra of if you know one tribe, you know one tribe, as helpful in grounding the way we think about research. And also just, I think the idea of what are you bringing to the community as a resource is helpful across all the populations we're talking about today. So thanks for that framework. Moving on, we'll next be hearing from Dr. Maria Patani. She'll share her learnings from the largest, most comprehensive study of the Latino population in U.S. history. Dr. Patani graduated as a physician in 1986 from the Universidad del Rosario in Bogota, Colombia. She's worked with the Hispanic Community Health Study since 2007. She is the clinic manager of the Miami Field Center located at the Behavioral Medicine Research Center at the University of Miami and the vice chair of the SOL Study Operations Committee. Dr. Patani is also responsible for overseeing participant retention, community relations, and dissemination of study results to local communities. During the course of the study, she's used different types of media, including TV and radio programs, as well as social media, to inform the community about pressing public health issues and to maintain participants' engagement. So welcome, Dr. Patani.
Thank you very much. It is a pleasure to be here with all of you. And it's very good that I was the last person to talk, because many of you have already mentioned important point that I'm gonna mention regarding our experience in the SOL study. So could you please move to the next slide? And the next one. Thank you. So the SOL study, or Hispanic Community Health Study, is a multi-center prospective population study. And as it was mentioned before, is the largest and most comprehensive study of Latino population in the history of the US. The study started in 2007 in the preparation phase, and we started examination in 2008. And between 2008 and 2011, we examined in 4 academic centers 16,415 Hispanic individuals. They were recruited from households in 4 communities of the United States, in the Bronx, in San Diego, in Chicago, and in Miami. And they were, we recruited individuals between 18 and 74 years of age at that time. And it included the diversity of the Hispanic population, people from all different places, Cuban, Dominican, etc. We have conducted, after the first examination, a second examination, and now we are, we already started the 3rd clinic visit that has been suspended due to the COVID epidemic, but that we hope to start pretty soon, or restart pretty soon. We're currently conducting the 12th year of annual follow-up. The next slide, please. So as it was mentioned before by Dr. Groins and by Lynn, the community involvement is very important. So in our study, we work with community members to learn about the characteristics of the community before the start of the study through focus groups. We also adapted the study design to the community characteristics. So the recruitment was done through households, so that other members of the family or several members of the family could be included in the study, which helped recruitment a lot. We also learned how to deal with gatekeepers, which could be sometimes the mother, sometimes the grandmother, who was the person that gave access to the household. We developed community support with the study, going to the neighborhoods, working with the churches, local governments, community organizations, and we created a community advisory board that advises, has provided advice throughout the study. In addition, we promoted education about research. So we explained to the community the purpose and the importance of the study and the value to the community. Next slide, please. The study personnel was chosen from the community. So they will know the community, and they are also invested in the research as members of the team. A very important point is to, along the way, promote professionalism and teamwork. That means providing the employees, the research team, training, support, to encourage them to be kind, to be responsible, to be flexible, and to be invested. The study personnel is bilingual, bicultural, and diverse to reflect the community. We always aim to provide a community and family-friendly environment at the clinic, that we do it with the staff and also with the physical space. Next slide, please. So the incentive. This is something very important when we do research. We should provide meaningful incentives in a timely manner. Sometimes we forget as researchers to do things in a timely manner. So if it's, for example, a test for the participant, it would be, because if for research purposes is given like 3 months after, it might not be of value. So in every incentive you provide, try to provide it in a way that gives the most benefit to the participants. In our case, we work also very hard to bond and build trust with the study participants. At every time we got to contact them through the telephone, in person when they came to the clinic, when we went to look for them in the community. And we work also very hard to present complex materials in an easy format. So for example, the informed consent was presented in a form of DVD because the informed consent was very lengthy, and we had people of all ages, of all education levels, so it was much easier to understand. We provide fact sheets and newsletters in simple language so that everybody can get their content. Other ways are to provide opportunities for additional incentives through participation in ancillary studies. Since this is a very large study, we can do this. Another thing is that we always show appreciation for the participation in research. And when we do it, when the participant is willing to participate, and also when they are not willing to participate, because this is a longitudinal study. If they still don't want to participate, they have contributed a lot to our learning. So we thank them all the time. And the other thing that we regularly do is provide small gifts with study logo and things like that. Next slide, please. Okay, another important point is to minimize the cost of participation. So we should, as it was mentioned before, Florencia mentioned this, provide compensation for transportation, parking, provide compensation for childcare costs, family-friendly space at the clinic. And also, this is a very important point, is to minimize the time spent at the research center. That means that you have to work on operational efficiency, work on exam flow, train your staff very well, and maintain your equipment and supplies so that the participants, when you have this attitude and you are efficient and you treat them well, they feel you're showing them that they are valuable to you. Next slide, please. Provide real benefit. And this is my insistence on this point is when we did the research, we started finding that many participants we have had a lot of findings of illness and high blood pressure, heart disease, all these things, and our population did not have access to health care. So we work to provide good health information on common findings, to provide free medical referrals, to provide community resources. For example, we did list of free clinics. We work agreements with community clinics to see soil participants, for example, for dental services at low cost. We share information when there were health fairs in our communities. All of that trying to help them because many of them did not have health care at the time. Next slide, please. This is to show, it's a little bit small and I apologize. This is to show, we did this, it's called a participant satisfaction survey with the exam visit. I have to tell you that the first examination took 7.5 hours of test. So it was very lengthy and tiring for them and for us as the research team. And we, at the very end, we put together this participation satisfaction survey, and we got 22% of the participants to answer this. And we got very good numbers after we had already had some practice at this point. But we had like the 98% of them say they enjoy their visit to the center. that their tests were explained clearly, that they were treated, they felt that they were treated good and respectfully, that we provided a friendly environment. So I just wanted to show you that. It is a lot of work. Next slide, please. But it is it's worth it. And it makes your study, your project successful if you work at all this. So thank you very much. Next slide. These are the references. And next slide, please. Thank you very much.
Thank you so much. I really love the approach of thinking from front end to back end of how someone would participate in a study, ways to make the study engaging and rewarding and easy on the study participant, and just kind of the whole wraparound idea of considerations for those populations. So thank you for everything that you shared. And I'm excited to transition us into the Q&A. So we have a little under 15 minutes left. Remember, for anyone who is attending the webinar, to please type in your questions, but I will kick it off and get started with a first question, which is probably on everyone's mind. It's coming up in every discipline, but how do we reach hard to reach, or as Lynn would have us frame it, easy to ignore populations in this new era of COVID-19? Recognizing that it's hard to build trust and relationships digitally. Also realizing that many of these populations also fall into the digital divide. And how can we engage them while keeping everyone safe? So not a small question, but I welcome if anyone is willing to go first.
I would say that you do everything you can. I would say that because these are difficult to reach, if you can, right now it's difficult to go in person, but you could do Dr. Simpson mentioned, radio, you could do media, social media, you can do emails, you can do phone calls. Right now we're working a lot with phone calls. You can send newsletters. You canvassing neighborhoods and stuff like that is not feasible, but you have to do it multiple ways. We have found that that's the best way to do it, is like every approach when we need to reach people. Thank you.
This is Ann Simpson. I also am thinking about that. It's not just us, there's a broader community. So how do you engage with community organizations? And when I moved, and I have not lived in Virginia very long, but one of the things I did immediately was get involved with some community organizations that were working on issues of social justice. And one of the things that the organization is doing, it really is focusing on making sure that people have access to food. And so engaging where people need it. They may not be interested in being part of an investigation at this point, but how do you help them in terms of making sure that their family is fed, that they continue to have housing, and those kinds of things? Those are critically important. So maintaining engagement at that level. And if you have a larger community of people, it's easier than just thinking about it one-on-one. But how does the community engage, and how do you engage with that community?
Thanks. Yeah, I think that's really important.
I'd like to add the importance of asking yourself certain questions. First of all, what can I give back? When we promote best practices around community engaged research, one of the basic values that we emphasize to all our investigators is going in with the idea of a mutually beneficial partnership, not what you're going to get out of it, but where is the mutual benefit? Also, what are you able to offer? What resources can you provide? And really keeping in mind the value of the time and effort that a community partner can, valuing their time and effort. Many times these community partners we work with are understaffed, overworked, underpaid, and the organization can benefit. It's not just remunerating the study participants, but compensating the organization for their time and effort. And so I cannot underestimate the importance of budgeting for the partnership and engagement. And if you don't know what to budget for, ask your community partner. I mean, that's sort of our starting point, is working with community partners. And but when you approach a community partner, how you approach that partner makes a big difference. And if you're come with to the table with the idea that you are there for a mutually beneficial endeavor, and that you're there for the community as well, not just to get study participants, the doors will open for you more openly. The doors will open for you more.
Yeah, I really loved coming from a background of having worked at a community-based organization. I loved seeing everyone advocating for budget line items to support both the community workers, and then also for providing incentives and providing a reason for people to participate, and to show them, even if it's a small token, like providing childcare, that you really thought about their experience and what might be barriers to engagement. We have another question. This one is actually directed specifically to Dr. Patani. So someone asked for the DVD consent. Did it include images and a video to help explain complex boilerplate language often found in consent forms? And if so, how long and expensive was it to produce?
Well, the first time there was like a full film crew. We found creative ways to make it less expensive. So the staff were the actors, and we found people in the community that had cooperated before to sit in for the recording. But it was like a film crew that came and that traveled to the 4 sites and did that. So that was quite expensive. I don't remember exactly. The second time, it was worked with the film department of one of the universities. So it was like there were some images that were used from the internet and all that, and it explained everything, because there is a lot of language that's very complex when you want to talk about genetics and certificate of confidentiality and data agreements and all that. So if you explain it and you show it, you use images. For example, for somebody that has a low reading level, it's much easier to understand the material visually. So that the second time was much cheaper. This time we have no budget for video, but we know the value of it. So we have created a PowerPoint presentation with voiceover to explain the consent. So there are ways to do it depending on how much budget you have, and like because we have bilingual staff, the study has a translation committee, so we translate the materials within that committee for free. There is no like extra, and then there is they just send it for a certification to a translation agency. So there are ways to do it in a less expensive way, and it explains all the points of the informed consent. Yes.
I love the creativity there, because it is so expensive to produce materials in film. But the workaround of creating a PowerPoint with voiceover sounds like a really affordable option for a lot of organizations looking to do outreach without a huge line item for video production. Also, being able to bring people on to make sure to either do translations themselves or to vet translations is so important, because I've found in my work that when you get something translated by a company, often it doesn't really resonate with the community, and the translations are super technical and it's not how people talk, and so it doesn't get through. I see Lynn nodding. I see a couple of people nodding in agreement that they've had that experience too.
I think there's also a huge difference between culturally competent translation and the literal translation you mentioned. So for example, with the Vietnamese population, we have had issues with professional translation services that have not been mindful of the fact that a lot of Vietnamese people came fleeing communist Vietnam, and so they're very sensitive to anything that's tied to communism. And so it might be professionally translated, but you're going to turn away and turn off a lot of participants just because they think you're a communist, which is accidental. But you know, if you don't have that context, you're going to make a really dangerous, an early trust-breaking experience for some of these folks. So yeah, I completely echo what folks are saying about a culturally competent translation, and also what Maria has mentioned about the fact that some folks are literate, not just in English, but in their own language. And so the role of visual materials and video materials is so valuable.
Yeah, exactly. And I think the process that many of you have pointed to with engaging community early and meaningfully helps you anticipate things like many communities wanting actually bilingual interpretations, not just pure in language materials, but side by side with English, so that they can kind of go back and forth between the two languages to figure out deeper meaning.
Another thing I want to mention that's valuable when you use something like a DVD or a presentation is that you can share it with the community, with the participant before they come to the center. So they can, let's say for us, it could be like an elderly person that always does it with the grandson or the son, but they are busy working, so they can watch it, look at it, and they come with questions, and you can answer their questions, their concerns. So when they come, they are kind of prepared and more knowledgeable about what's going to happen, which at the end translates in better participation, retention, and all that. So it's to our benefit, really, to do that work up front.
Thank you. So we have another specific question for Turner. When researchers have federal, particularly NIH funding, and are working with tribal governments, how do you negotiate the data ownership piece with tribes, understanding that NIH mandates public access?
That's a good question. I think that's been an evolving issue at NIH for a long time. From what I understand, I think there's a new committee that's been developed to address that issue. So I would talk to your project officer early and about these issues and talk to the tribe. You know, so you would have to orchestrate these conversations and request these conversations to be had, and I would do it sooner than later.
Thank you. So really just negotiating that with your product officer and coming up with something specific to your study.
That's, yeah, that's agreeable to NIH as well as the tribe. Yeah, it can be done. It just is going to take a lot. It takes some effort.
This is sort of related to the next question, which is generally for all of the panelists, but at what stage of research should researchers engage with community organizations? And I'm wondering if maybe we can start with Dr. Simpson, not to volunteer you, but I want to make sure we hear from all the panelists. So Dr. Simpson, if you had thoughts about at what stage of research people should engage community-based organizations. Oh, I believe you're on mute. Let me try to unmute you, Dr. Simpson. We can't hear you right now. Oh,
I'm not good with this
oh,
computer. But
great. We can hear you.
okay, before you get started on a research, in the thinking process should be thinking about the community and considering how you're going to engage with them from the beginning. Because if you don't, you can do a lot of work and then not be able to do your project. So you really have to engage with them beforehand. It should
So
be a partnership.
I was curious if you wanted to elaborate, or anyone else as well, but I think a lot of times the structure of these engagements, right, is like writing a grant and you think, oh, I'm going to work with this population. But does anyone have a success they can share around bringing people to the table in those early stages? So maybe it's by doing a focus group or convening an advisory committee, but what meaningful ways have you been able to bring people on really early?
Like the SOL study work with focus groups. And then you can, if you do it from the planning stages, you can address the barriers right there and then. For example, the Hispanic community, you know, there is familism, there are certain things that are cultural. So if you're going to recruit people in the Hispanic community that are, let's say, 70 years old, they are likely not going to come on their own. So if you look at the group that you're going to engage, and you can see, okay, then I have to bring somebody else in the family, and then that grandmother, or it's going to come without any problem. Or if you see that you have like a large group of single mothers in the community, in the group that you're going to engage, then you say, okay, I have to budget for childcare. Or there is a lot of people that they don't have a bus stop close by. So how do I address that? Or, you know, different things. So you have to do it from the planning stage, definitely.
Thank you, Dr. Botani.
And
Oh,
just
sorry, go
one,
ahead.
sometimes the community tells you what they need. I received a grant to do a project. I was planning to do one project, and the community said, this is what we need. So listening to the community is always important.
Thanks. Yeah, that it seems so basic, but it's so quintessential and often ignored when you have an agenda that you think you want to accomplish.
If I could just add something
sure.
to that, Lauren, really quickly. We focus on helping investigators build community partnership with, mostly with community organizations. And what we encourage investigators to do is to establish those relationships before a grant is even, you know, before an RFA comes out. So, you know, joining coalitions, joining existing groups in the community where you can start building those connections and relationships, and you're demonstrating that you are invested in the community, is going to, you know, really help you, because that, you know, you've got 6 weeks to submit a grant. You've got a lot of work to do in that time, and having those established relationships is going to help a lot.
Thank you. So we have several more questions and only maybe 2 minutes. So I do encourage you, if your question doesn't get answered, to reach out directly to all the panelists. But for our last question, and maybe I can hear from Lynn or Turner first, is when a study is working with the community, but it extends for a long time, how do you keep participants engaged, and how do you keep up with the community?
For me, I had a KO1 in 2005, and it included conducting interviewing of over 500 tribal elders in a particular tribe. And so it took several years. And what we did is we gave presentations in the community We mailed a newsletter, a quarterly newsletter to the participants with some information about some of our preliminary findings and some resources. So that's how we did it. And dissemination is really critical. So so we disseminate along the way, but as well as significant dissemination, not publications, but dissemination to the community. And so that's how your partnerships can tell you where are some good venues to do that. So to tribal council, to the tribe's health board, to community club meetings and things like that.
Thank you. That's helpful. Lynn, any closing thoughts before we transition to the close?
I think Turner covered it pretty well. I think similarly, we just made sure to disseminate information that we thought would add value to their work. So mine was more around social needs pilot, and when we were able to tell our clinical staff, like, this is what we found out about your patient's needs, that sort of drew them in and made them feel like there was a value add for them and why there was a reason for us to collect this data on the patient population. So it's very similar to what Turner said.
So I'm hearing really following through and making sure that whatever you promise in the beginning that you will give back to community, you really stick to your word. Again, it sounds basic, but it's so critically important.
I like to under promise and over deliver.
Well, thank you all panelists so much for your valuable presentations and your time in the Q&A. I'm going to introduce a staff from NHCOA to close it out for us. So thanks everyone, and I will now introduce Cristina Pacheco. So Ms. Pacheco is the Director of Development and Policy for the National Hispanic Council on Aging. She graduated from William Mitchell College of Law in St. Paul, Minnesota in 2008 with her Juris Doctor, and from the University of Kansas Medical Center in Kansas City, Kansas, with her Master of Public Health. Ms. Pacheco has worked in the field of policy and law for more than 12 years and in the field of public health for over 12 years as a community-based participatory researcher with Indigenous and Latinx communities. Welcome, Ms. Pacheco, for our closing remarks.
Welcome, and thank you, Lauren. On behalf of the National Hispanic Council on Aging, I would like to thank our panelists for their insights on this very important topic. We would also like to thank our participants, the Diverse Elders Coalition for co-hosting this webinar with us, and the All of Us Research Program. And Lynn, I would specifically like to thank you for helping decolonize my vocabulary. The All of Us Research Program is inviting 1 million people across the United States to help build one of the most diverse health databases in history that researchers can pull from when developing better treatments to prevent different diseases. This research program is so important because participants in research should reflect the diversity of our culture and conditions, taking into account race, ethnicity, gender, age, etc. The lack of diversity among research participants has serious ethical and research consequences. This includes impeding our ability to generalize study results, make medical advancements of effective therapies, and it prevents some populations from experiencing the benefits of research innovations and the receipt of high-quality healthcare. The work being done through the All of Us program is important because certain populations have historically not engaged in research for a myriad of reasons, including historical research and medical transgressions, such as the Tuskegee syphilis study and the Havasupai Diabetes Project, distrust, researcher and physician bias, a lack of access, and limited education and information about research participation. I also want to add that many communities do not distinguish between abuses that happen in medical settings and health research. But as we have learned, there are ways to overcome these barriers. Partnering with trusted community-based organizations that can serve as a gateway to many communities, such as the Diverse Elders Coalition and the National Hispanic Council on Aging, can help researchers diversify their participant pools and engage easy-to-ignore populations. It is important to note that not all communities are the same, and there is no one-size-fits-all model for engaging easy-to-ignore communities. Researchers and healthcare provider organizations must invest time in creating these relationships and invest in these communities, thereby creating true partnerships instead of just gaining unidirectional benefits. These relationships must be cultivated and require a significant investment of time and money, and that is where partnering with organizations like ours can help. the outcome is worth it. A few cautionary notes. While it can take a long time to develop trusting relationships with easy to ignore populations, it takes but a second to ruin those relationships. And although we often point to historical examples of research and medical abuses, there are current examples as well, including the recent news about a formal complaint filed alleging that unnecessary hysterectomies were being performed on women in custody at Immigration and Customs Enforcement's Irwin County Detention Center in Georgia. Trust building is an ongoing process, and working with community-based organizations can help researchers and HPOs achieve meaningful collaborations with easy-to-ignore communities, benefiting all and ensuring that all of us participants reflect the rich diversity of the United States, thereby leading to medical discoveries that can help make healthcare better for everyone. Thank you.
Thank you, Christina. Thanks everyone who joined us today, and feel free to follow NHCOA on Twitter, Instagram, Facebook, and YouTube. We'll be posting this video recording on NHCOA's YouTube channel. Thank you.